Good evening. I'm Dr. Richard Miser. I'm the lead physician for Adena Medical Group, and welcome to Joint Pain Webinar. We're on the second floor of the new, beautiful Adena Orthopedic and Spine Institute. Today we're going to talk about pain, joint pain. We're going to talk about what can be done to prevent it, what we need to do to treat it, and also if we have to have surgery, what the expectations are for surgery. Today I'm joined by two orthopedic surgeons, Dr. Nicole Meschbach and Dr. Gus Barrazueta. Tell us a little bit about yourself.
I'm Nicole Meshbach. Thanks for having me, by the way. I'm one of the hip and knee replacement surgeons here at Adena. I'm originally from Chicago, and then I trained at Ohio State in just orthopedic surgery. I did an additional year of training as my fellowship in just hip and knee replacements. I was in practice at Ohio State for a number of years, and I made my way down here.
Awesome. Dr. Barrazueta?
I'm Gus Barrazueta. I'm one of the shoulder, elbow, and hand surgeons here at Adena. I grew up in Tampa, Florida. I did my orthopedic training in Boston at Tufts Medical Center, and then I moved to Columbus to do my fellowship subspecialty training at Ohio State University in upper extremity surgery. Liked it, so I liked the area, so I stuck around, and here I am.
Awesome. Well, we're glad you're here. You guys have been all over, lots of experience. That's wonderful. As a reminder, please remember to send in your questions because we're going to ask the questions of these two a little bit later. So we'll just start right off. Can you explain exactly what is joint pain? I've got patients who come in my office and, as a primary care doc, and they say my leg hurts or my hip hurts, and it's sometimes hard to figure out, okay, is it joint, is it muscle, what is it? So what is joint pain?
Joint pain is pretty common. I mean, it can affect shoulders, hips, knees, ankles, hands, but it's kind of pain that you feel deep down inside as opposed to more temporary pain from a muscle strain or an ache, something like that. But it's that pain that kind of sticks around that is worth getting checked out.
Can we prevent joint pain?
Sometimes yes, sometimes no. Depends if kind of what your history was, if you've had a prior injury, or what the extent of your maybe arthritis is. The research shows that the best way to really prevent joint pain is to keep your weight down, have a kind of a low sugar diet, which can help with inflammation. Other things that would potentially be modifiable, I guess, would be to exercise, keep yourself mobile, but honestly, keeping your weight down is really the best.
Good ideas. It's hard for patients to understand that exercise actually can help prevent joint pain because they figure out that it's going to just make the joint pain worse.
Absolutely.
So what can be done to treat it that maybe is not surgical?
So kind of depending on, again, your history and what you've already tried, some things that could be helpful would be physical therapy. So if this is just a muscle issue or tendon ligament, maybe we can address those with just certain exercises. Physical therapy is kind of the first step, and once we've tried that and failed that, we move on to the tougher stuff. Injection therapy can be helpful, whether that's a steroid injection or some of the viscose supplementation. Anti-inflammatories are the best medication for joint pain, so they're going to help with swelling in the joint, which can be really uncomfortable and painful, especially as you're weight bearing. And lastly, using a brace can sometimes be helpful for example, for a knee, not so much for a hip or a shoulder, but something that you could get fitted here that we have available. So all those would be good non-operative options, and if you've tried those and everything else has failed, then we start to talk about surgical options.
So tell me what that viscose supplementation, what's that mean for people out there?
So that's a type of injection for the knee joint. It's almost like a lubricant that's injected just directly into the joint and it stays there. So that can help with kind of pain control as you have little space in there with degenerating cartilage. And you can get those done up to every 6 months, and we can do those here at Adena.
Awesome. Dr. Barrazueta, if I have shoulder pain, what does that mean? How do I know it's time to talk to you?
Well, I think with shoulder pain, if it's ongoing pain, if it's not something that goes away, in a couple weeks or so, if it's been a couple months and it's unrelenting, then I think it's important to see someone for it because there's so many different causes for shoulder pain that once you get evaluated and you tease out what that cause is, it'll kind of gear the treatment for it. And so whether that be physical therapy or some other type of treatment, it kind of varies depending on what the cause is of the shoulder pain. So if it's ongoing, I think it's important to get evaluated for it.
So do injections help?
They do. Similar to hips and knees, there's a lot of non-operative treatments that help in the shoulder. Injections, in particular for arthritis and for other pathologies in the shoulder, do help a lot and can either take away the pain, or at the very least, prolong the time that you have until you get a major surgery like a shoulder replacement. Other things help too, things like activity modification. When you have arthritis in the shoulder, it's important to not stress it too much. In the shoulder, that particularly means avoiding heavy weightlifting above overhead activities. Things like physical therapy and having a therapist kind of guide you on how to do that, stretching out the shoulder, because when you get shoulder pathology, whether that's arthritis or anything else in the shoulder, one of the things that can happen is the soft tissues tend to kind of contract, and so that can be painful too. And so that's where therapy can kind of play a big role in that.
So therapy is important.
Yeah.
But how do I know when it's time to talk about surgery with you?
Well, a couple things. So if you've gone through the regimen of the non-operative treatment and you've done the therapy and the anti-inflammatories aren't working anymore and the cortisone injections aren't working anymore, if you've done that and you get to a point where the pain is affecting your quality of life, doing things that you love to do, things like picking up your grandchildren, picking up groceries, even washing your hair, it's important to maintain those things in life. And so when it's affecting those things, or even getting a good night's sleep, then I think it's time to have that conversation with your surgeon.
Dr. Meshbach, are there more things to think about before considering surgery? Getting ready for surgery?
Right. So something to kind of keep in mind is you want to be the healthiest you can be. So we have a team that helps get us optimized, where we'll kind of go through medical conditions and make sure everything is as safe as it can possibly be before surgery. We try to get everyone at a healthy weight. So we try to aim for a BMI less than 40. BMI is your body mass index, so it takes into account your height and your weight. So if that's a modifiable risk factor, your weight, the lower we can get that the better. We also really encourage smoking cessation, which is easier said than done.
That's a key, yes.
And we certainly have resources that can help folks with that. The nicotine can act as kind of a vasoconstrictor, make your blood vessels small, and we need all the blood to get to that area to help it to heal. So smoking cessation is key.
When you do surgery, you like to do an anterior approach to hip surgery. Can you explain to people what that means, why you like to do that? What's the benefit for me if I need hip surgery?
I personally like the anterior approach to the hip, and that's why I did an extra fellowship in it to become specialty trained in that. So the anterior approach to the hip involves using a smaller incision. It's in the front of the hip. I always say it's about the length of my finger here. You go in between the muscle groups. You don't have to cut any muscles or tendons, and once you kind of spread the muscles apart, you're looking directly at the hip. So if you don't have to cut any muscles, you can have less pain, recover your function quicker, using less pain medicine after surgery, up on your feet and moving. So it does take kind of extra specialty training for that, because there are complications that can be associated with it. But the benefits to it are pretty great. So with less muscle damage, people recover much quicker in the first 6 weeks. Research does show that even if you don't have that approach and you still have a posterior approach, outcomes are the same at a year. So
if I don't smoke, I'm hopefully reasonable health and I exercise, but I need a hip replacement and I go for that, what can I expect in terms of my stay in this hospital?
So the surgery itself is just on the first floor. Once you're done with surgery, you'll head up to the 4th floor. So once you're up there, you'll be getting physical therapy at least the day of surgery, within hours of getting to your bed. You'll get several more sessions before we determine if you're safe to go home. When you're here in the hospital, you're going to get occupational therapy as well to help you with activities of daily living, so you can get used to your regular activities when you get back home. We do help with pain control and getting your pain at a manageable level before we get you home as well. And we just want to make sure that you're safe, comfortable, and confident before we can let you progress and get home.
If things go well, do I go home in 1 day, 2 days? How many days typically?
So it kind of depends on your medical background, your history. We really aim to get folks home the day after surgery. Some folks would even be a candidate to go home the same day, but again, depends on your history, your medical history. So we try to get you home the day afterwards, but things can always change.
Wow.
So
that's pretty fast.
It is.
Pretty fast. Please remember to send in your questions while we're talking. Dr. Barrazueta actually has a patient who had total shoulder surgery, Ruth, and she wants to share that story with us.
Hi, I'm Ruth. I live in Pike County, Ohio, and I came to Adena Spine and Orthopedic Institute for my shoulder surgery. I was still living in Columbus when my pain started, and we were in the process of moving back down to Pike County. And in the move, my right shoulder was causing me a lot of trouble, not being able to lift without pain, all of that sort of thing. And I couldn't sleep at night. And it just kept getting worse and worse. Even trying to brush your hair, because I couldn't lift my arm. My arm just didn't want to go up that high. Making a bed was difficult. Washing dishes, because moving your arm with the shoulder, that was difficult. Putting on clothes became difficult. I had a cortisone injection, which gave me relief for 2 days, and it should have been a lot longer than that, but my pain was too far gone at that point. I knew it was time for surgery when I couldn't sleep through the night. I would put pillows under my arm to try to get situated, and it still wouldn't help. Woke up tired, exhausted, and when I went to physical therapy to try it before surgery, I couldn't do many of the things that I should have been able to do. And they, at that point, the physical therapist said it was time for surgery, if that's what I chose to do. Dr. Barrazueta said that he was going to do a reverse total shoulder and rotator cuff repair. The hospital stay wasn't that difficult. I mean, the pain was, you know, not fun, but it wasn't horrendous either. So it was tolerable. To totally be able to raise my arm up again, it was probably at least 4 to 6 weeks with physical therapy and doing their exercises to be able to raise it all the way up again. Yes, I'm doing my daily activities again. My surgery was in November, and I can wash dishes without wanting to scream. I can take care of my cabin where I live, my animals. So yes, I'm back to where I was. I don't have any pain now at all. I was lucky that I didn't have a lot of pain with the shoulder repair. Absolutely recommend Adena and the Orthopedic Spine Institute here, because everyone that I ran into or had was extremely helpful. And the care from the nurses on the 4th floor was really good. I liked it that Dr. Barrazueta came up and talked to me, because his office is a floor below, so he could run up and say, "You're getting ready to go home. This is what I want you to do." So that was very good. You just don't get that at the bigger hospitals in Columbus, where I've had multiple surgeries.
Thank you, Ruth, for sharing that story with us. When you sign up to get a total joint here at Adena, we take continuum of care very important. You basically develop a close relationship with the surgeon from the moment we meet you until well after your surgery is done. And so continuum of care is very important to us here.
Awesome. So it's a team approach.
It really is.
Total team approach. And speaking of teams, we have Amanda Ashworth, and you are a nurse navigator,
Yes.
right?
Yep.
Can you tell us what that means, navigator, nurse navigator, and how that plays in the orthopedic system?
Yeah, so a nurse navigator is like a liaison, an advocate for patients. As a total joint orthopedic nurse navigator, we work with patients from the time that they become candidates for a total joint replacement. And then we work with them clear through the post-operative period for weeks, even months. We work with them prior to, during, and after their discharge. So we are with them throughout the whole process.
So if I'm a typical patient, how long in advance would you be working with me and getting me ready for surgery?
Yeah, so that just depends. So as soon as you see the surgeon in the office, you get that consult, and they determine you're a total joint candidate, it could be anywhere from weeks to months. So there's certain guidelines or criteria that you have to meet to be able to have surgery. Just because you're a candidate doesn't mean you're going to be able to have surgery right away. So if you don't meet those guidelines, we continue to work with you until you do meet those guidelines, and sometimes that can take months, sometimes it's just weeks. So, but we're with you, throughout that whole process, and then once you're able to have surgery, we stay with you and continue to work with you post-discharge.
So the team includes physical therapy, occupational therapy, maybe a dietitian?
Yeah, yep. So therapy, dietitians, we have a great program that we have set up through the YMCA here in Ross County and Fayette County. So if your BMI is over 40 and you need to lose weight, it's a free 8-week program that we have through our Adena Health Foundation, and the patients can go there at no cost to them, and they help with them with they have a personal trainer, so they help them with their weight loss and diet, and trying to help them get to where they need to be able to have surgery.
So why should I send my patient to you in the surgical team here at Adena?
Yeah, well, here at Adena Orthopedics, we have great surgeons. They're highly skilled. So not only do you have those highly skilled surgeons, you're also working with a team, a cohesive team, and we work with the patient. So we want to help them reach their goals. And so, we want to make sure that we have your best interests in mind, ensuring that you're healthy throughout the whole process, throughout that continuum of care. You always have a nurse navigator that is the direct contact. So like I said, we're a liaison between the patient and the surgeon. So if you need anything at all, you have our business card, you have our direct contact. We can be easily reached and then get to that surgeon right away for anything that you may need.
That's awesome. I know my patients appreciate that. It's hard sometimes to, I think patients don't want to bother the surgeon
Right.
or family doctor about
Yeah.
that, but they will probably contact you before they would me. So
Absolutely,
appreciate
yeah.
that. Please remember to send in your questions. Actually, we do have a question. Dr. Meshbach, this sounds like it's up your alley.
All right.
I fell and hit the inside of my right knee. I broke my tibia and my fibula at the same time. My knee isn't healing at all. Any ideas?
So we would first start off with some x-rays just to kind of see where you're at in the healing process. Sometimes a CT scan is even better to get a 3D picture of your bones and what's going on. The top of your tibia does involve the knee joint.
And the tibia is this big bone
Your
in
big
the front,
shin bone.
right?
Yep,
Mhm.
that bottom part of your knee joint there. So sometimes the fractures in that area can extend into the joint and disrupt the joint surface or the cartilage there. And disrupting that cartilage can set you off on a cascade of degeneration, which leads to arthritis. So we would investigate a little further to see kind of how the bone is healing, how it affected the joint, and then see, first of all, what we could do that's maybe not surgery to try to help with pain. And if all those things fail, then the last resort is joint replacement.
Very good. This is a question that I get in the office actually when I have a patient who they say, I had an x-ray of my knee and the ER doctor said I have all kinds of bad arthritis. And they want to know, well, should I go see a surgeon? So when is the right time to consider doing surgery on somebody?
So there's a couple different types of arthritis, I guess, to begin with. So osteoarthritis is that wear and tear, degenerative arthritis, kind of from overuse, can be from weight, and can be just as we get older. So osteoarthritis is probably the most common thing we see, along with rheumatoid arthritis, psoriatic arthritis, and even post-traumatic arthritis. So you had a previous injury and maybe the joint didn't heal well after that. So if you've seen your primary care doctor or maybe a subspecialist if you have rheumatoid arthritis and they've tried all the medications, all the physical therapy, exercises that they possibly can, there are some things we can offer here at the Adena Orthopedic and Spine Institute to maybe help avoid surgery. But again, if we've tried all those things and nothing else is really helping and it's really affecting quality of life, then we talk about surgery.
Yeah. I think the key is the quality of life. Because I tell patients, well, if you can do everything you want to do, you're probably not looking at surgery, regardless of what the x-ray shows. Is that right?
Right.
So it could be a horrible looking x-ray, but if people are doing everything they want to do and they do it safely, you got to wait until you say, okay, I give up. Uncle, I give up, I'm ready for surgery, right?
There are plenty of folks walking around with arthritis that don't even know it, but if it starts to bother you and that pain just doesn't go away and continues to get worse, then we've got options.
What is a typical age range for surgery? I got some people who say, am I too young for knee surgery or hip surgery, or am I too old for surgery?
I think as younger folks are becoming more active and getting more involved in sports at younger ages, we're starting to see younger folks have post-traumatic arthritis or just that wear and tear arthritis. So folks come in of all ages. I mean, I see folks in their 20s up to their 90s.
90s?
So
Really?
Age is just a number, really, and it kind of depends on what your joints have been through. But, you know, as we do start to get older, we do worry a little bit about the age of the other things inside of us, so how we process medications and anesthesia. That's why we do work with primary care doctors and our optimization team to make sure you're the safest and healthiest you can be before we undergo surgery.
Good advice. You may have answered this, but there's a little extra thing I said. After a total joint replacement, am I able to go home? And what if I live alone and need help?
We always prefer folks to go home. I think you feel better at home. You can sleep in your own bed. You've got all your familiar things nearby. You know your house, and it just feels more comfortable. But there are some times when it's maybe not safe to go home and we need to consider other options. So if you live alone and you don't have anyone that could be with you for the first 2 weeks after surgery, going somewhere like a facility that has a swing bed is a good option. You'll get pretty aggressive physical therapy to the point where you'll feel comfortable to do these things on your own. And when you graduate, you can head home. Most people aren't spending longer than 2 weeks in a facility like that. But it's, again, if you have no help at home, we have those options. We prefer for folks not to go to nursing homes. I don't think people will get the amount of physical therapy they're hoping for there. There's lots of bad infections there and whatnot, and if you just had a joint replacement, we try to avoid all that. So going home is ideal, but there are backup options if we need it.
Well, you just opened the door for me to throw out a little commercial there, because our 3 critical access hospitals have swing beds. So swing bed is basically, it's a Medicare approved bed. Nothing swings. It's just an extended care bed, right? Yes. And in Greenfield Area Medical Center actually has inpatient rehab and has PT, OT, speech therapy, recreational therapy, therapeutic garden. So there's lots of things available for recuperation there.
I've visited those facilities, and the staff there is wonderful. The physical therapists, occupational therapists, they are wonderful, and they will help get you back on your feet quickly.
I think you may have answered this question. Well, after surgery, is physical therapy always needed?
Yes.
Yep.
Yes, yes,
absolutely.
yes. Pretty
Resounding
uniform
yes.
there, yes. In fact, would you want to do surgery on someone who says, well, I don't want to go through any kind of physical therapy?
I always tell folks you're going to get out of your joint replacement what you put into it, and that's especially true with the knee. Physical therapy is really helpful to have just someone watching you, making sure your gait pattern is appropriate, your range of motion is getting to where it needs to be at certain time points in your therapy course. So it's very helpful to go in person. Sometimes that's not always an option. So even just going once, they can teach you a home exercise program. That can be helpful too.
Actually, it sounds like physical therapy is good, maybe even occupational therapy before you have surgery, in terms of knowing how to use the equipment. Like after shoulder surgery, they're going to be bound up like this pretty much, right?
Yeah.
So is there a program in the team approach for kind of pre-operative therapy, and what kind of things would they do there?
It's a patient individual specific. Some people kind of need that education beforehand. That's particular to the surgery and to the post-op rehab and what they can expect. For shoulder arthroplasty, for shoulder replacement, a lot of it can be learned in the immediate post-op period. I start physical therapy immediately after surgery. The first 2 weeks are kind of taking it easy and learning how to take that sling on and off, how to take a shower, just gentle motions here and there, how to keep your elbow motion intact, because the elbow can get just as stiff as the shoulder after shoulder surgery. And then at the 2 week mark is really when you start working more and more on building up that shoulder strength and that shoulder motion again. But I mean, I tell patients it's a big commitment to go through a shoulder replacement, and the biggest commitment is going through that therapy regimen. And I tell people it's a good 3-month recovery at least. And so as long as the patient is committed and is willing to do the work, the outcomes are very good.
So at 3 months, they'll be back to doing everything they want to do?
Most people, plus or minus a month, but at 3 months, most restrictions are lifted, with the exception of the chronic restrictions that you may have, depending on your surgery.
What if I am not a surgical candidate due to my poor health?
Well, the nice thing about the optimization team that we have here and the anesthesiology team that we have here is that you'd be surprised. You'd be surprised with the comorbidities that patients have, how well we can get them through surgery. I have patients come in that say, I've been told before that I'm not a candidate for surgery, and we put them through the process, and they end up being able to have the surgery done. So that's one. But two, yes, if you really are not a candidate for surgery, there are things that we can do, which include the non-operative measures, to kind of get you by as much as we can, get your pain reduced as much as possible.
So for non-operative options, who else is on your team here for the non-operative stuff?
You want to answer that?
Yeah, absolutely. So we currently have a team of 3 orthopedic nurse navigators, and so in our department, what we do is work with patients individually, one-on-one, making sure that we go through that in-depth health risk assessment, and at that time when we do that, we are working with their specialty provider, so any specialty provider that they see. So for example, if they have significant cardiac issues, we're going to reach out to their cardiologist and do everything that we can to get them optimized, to make sure that they're in the best optimal state, healthy enough to be able to have surgery. If not, then we'll take another approach. We'll do prehab, so we'll work with therapy, prior to get them strong again. But we work with multiple different avenues. Smoking cessation, we have a quit clinic that we, refer people to. We have our nutritionists, dietitians. If you're diabetic, anything that you have going on, we have somebody that we can reach out to kind of help you. We don't just leave you hanging.
The other nice thing about the Adena Orthopedic and Spine Institute is that we have a whole team here of non-operative sports medicine doctors. And so their whole training is non-operative treatment of the musculoskeletal system. And so they treat a lot of these patients that need that non-operative treatment, that can't have the surgery, but need their pain to be reduced. And so we use them very well.
So are there preferences of a patient making an appointment or calling your office directly, or should they call the sports medicine doctors first, or what's your preference?
Well, I think it kind of depends. If you've seen somebody before, like if you've seen your primary care doctor before, you've had x-rays done, and you've had some of these non-operative measures done, then maybe it is worthwhile to see the surgeon right off the bat. If you haven't been evaluated at all, it may be the patient's benefit to go through that, measures, all those non-operative measures with one of our sports medicine doctors. And the sports medicine doctors are very good at both diagnosing and treating these things, and they're also really good at knowing, hey, maybe it's time to get our surgical colleagues, involved. And so I think using either one of us is definitely beneficial.
Do you have any preferences?
Well, I just wanted to add to that too. Some folks have kind of 2 issues going on at the same time, and then we have to kind of figure out what takes priority or what should be addressed first. We see a lot of folks with back issues or spine issues, and on the second floor here we have the spine team that can maybe address that at the same time. But we often have to have a discussion of what kind of takes priority, what's the more pressing matter. But we have a whole team here that can help with all those things.
So if I need my hip done, but I also need my shoulder done, so which do you do first? How do you manage that, and why?
Great debate. I do tell folks that after a hip or a knee replacement, you will be using a walker for additional support until you kind of get your balance and get your strength back. So if you have to use your upper extremities to depend on that walker, then you have to kind of figure out how much is that shoulder bothering you, maybe what's more painful, and address that first. But it's on a kind of case-by-case basis.
Okay. So it's important to see the physical therapist first, maybe, to go through the physical therapy, and they would say, oh, your shoulder is worse than your hip, or vice versa.
Absolutely.
Please remember to send your questions in. because we have the great advice right here, right available. So in terms of, we've talked about hips. Tell me a little bit more about your knee surgeries.
So knee surgery, kind of same process as getting optimized. You'll come meet us in clinic. We'll, discuss all the non-operative options first, always, and then, then we kind of delve into surgery. I think knee replacement is a little more involved than hip replacement. It's a much tougher recovery, a little bit more involved with physical therapy. So I definitely have longer discussions with patients when it comes to knee replacement. The physical therapy is imperative. And again, you'll get out of that knee what you put into it. But it's pretty easy after knee surgery to say, this hurts really bad, I just can't do the physical therapy, or I don't want to. And we have to kind of be your cheerleader and say, hey, we got to push through this a little bit so that you get that range of motion that you want, you get your strength back in your knee so that we can get you up and moving. So knee replacement tends to be a little more painful than hip replacement for whatever reason. Lots of theories on that. But it's definitely a little bit longer discussion in terms of setting expectations and what to be prepared for.
I would think people out there are thinking, but my knee is smaller than my hip. Why, why is this a harder one to recuperate from?
It's a much more complex joint. We depend on ligaments on the inside and the outside of the knee to help us balance the knee so that it's not going to give way on you and it's nice and stable. I would just overall say it's a more complex joint. But if you think about it too, your kneecap's right under your skin here. That skin here is pretty thin. And when you get swelling in this area, it tends to have nowhere to go. So it can be pretty darn painful, especially just being a hinge joint like this, and it's a weight-bearing joint. So those are kind of my theories of why it's a little more painful than the hip, but it's a little up for debate.
Speaking of pain, I think in some ways it's good for us to relate to patients and vice versa. When we've been through something that a patient's going through, have you been through this type of surgery?
Unfortunately, a little bit, yes. So I've had 4 knee surgeries myself. I've had both my ACLs done and then 2 other meniscus repairs. So these were all done, 20 years ago. But research has shown that with ACL injuries, your likelihood of developing arthritis can be more than just the average person. So we're more prone to develop arthritis at earlier ages. So I can certainly identify with patients that are going through this that have had prior injuries. I have not had a knee replacement myself, but I can at least relate to the build up to it.
Yep. It takes a lot of work.
It does.
Before and after, a lot of recuperation. Tell me about shoulder surgeries other than the total joint surgery. What other kind of things do you do in the shoulder?
Yeah, so a lot of things. One of the most common things that I see is dysfunction of the rotator cuff, whether that's partial tears, tendonitis, or full rotator cuff tears. And rotator cuff tears come in, I say 2 big families. The chronic degenerative wear and tear, wearing out your rotator cuff, or I've had a fall or a car accident and the traumatic tears. And then there's, the biceps tendon is actually a common area to be hurt in the shoulder. The biceps tendon goes all the way into the shoulder joint itself and attaches onto the labrum. And so when that gets torn, it's a pretty big pain generator. And then your labrum, all the way around your glenoid, which is the socket of the ball and socket joint, that can get torn, that can get frayed. You can develop frozen shoulder, which is something I see a lot of, which is a disease of the lining of the shoulder of the capsule, where it gets really inflamed and really contracted, and it becomes very painful. But there's a lot of, and then there's trauma too. There's fractures and breaks in the shoulder. There's a lot of different things that we treat in the shoulder for sure.
Tell me what the pandemic has done in terms of surgeries. Are people putting off their surgeries? Are they coming more often? Are they injuring themselves? Do you see any change in the kind of usual pattern of surgeries during what we've been through?
Yeah, I think for a while people were putting off getting help that they need and getting surgery. I think thankfully we're heading towards a little bit more regression to the mean, and people are starting to normalize a little bit as far as getting the help that they need and the care that they need. But for a while people were living with it because the pandemic was a scare. It was a scare for all of us, and so people were putting up with more than they were used to. And it's a kudos to the community to be able to do that. But now that we're kind of getting over that a little bit, we're starting to see a little bit more of an influx of patients that, hey, I've had this pain that's been killing me for a couple of years now that I haven't really sought care because of the pandemic. And so we're starting to see those patients more and more.
So right now there's no restrictions on getting surgeries done?
No.
Yeah. One of the things that I think patients would like to know is a little bit about the two of you in terms of when you're not here operating and seeing patients in the clinic, what do you like to do for fun?
I'm married. I have 2 kids, so they kind of occupy all my time. But I like to do anything and everything outdoors. I do as much as I can with my knees. I try to avoid kind of repetitive activities. I don't run anymore, but I certainly enjoy anything and everything outside.
Awesome.
I'm married as well. We are expecting our first child actually coming up here soon.
Oh,
it's a girl, so we're very excited for that. Yes,
excitement.
thank you. But no, my wife and I, we like to stay, social and active. We like to kind of explore the different restaurants around town, and, do things outdoors. We're both sports fans. We like to watch sports a lot, get together with friends, try to stay as social as possible. I think it's really healthy to do that. I think all my time's going to be taken up by our baby when she comes, but, so we're trying to make the most of the time that we have now, but yeah. No.
You can get some advice right here.
That's right.
Let's talk about the building a little bit. I mean, it's wonderful to have this center. It's great. It's state of the art. It's beautiful. If people haven't seen it, they're really missing something. But I think one of the other aspects is we have great specialists here. We have good people, great specialists, lots of experience, surgical and non-surgical. From a primary care point of view, for me, that's the most important thing is the people who work here. But besides that, in terms of the building, tell us about this center. What makes this unique? What have you found that really people out there may not know about this place?
I think this is a really unique setup here to have just a dedicated orthopedic hospital. I mean, the operating room's on the first floor, the second 2 floors are clinics, and then where you would be after surgery is on the 4th floor. Everything is all here in this building. It's got state-of-the-art technology, the most up-to-date technology that we could ask for. So certainly the building is set up for success, but you're absolutely right. The team here is wonderful. I'm very lucky to be part of a talented team like this, but everyone's very easy to work with, easy to get along with. I would certainly send anyone in my family to any of the providers here.
Awesome.
Yeah, the nice thing is the totality of care that we have here for the musculoskeletal system. Whether it's spine issue, a foot and ankle issue, sports issue, whatever it may be, we have everything covered here, and so it's nice for even at a big institutions when you have certain issues, you're getting driven around have to go to different offices all over the place. And the nice thing about Adena is our home base is here, and we have everything here, but we also do have satellite hospitals and offices for people that are closer to home there, and so I think we cover it all, which is nice. People don't have to leave the counties surrounding this area to get the care that they need. What's
the most kind of fun surgery that you like to do? Is there something you like? I love to do X procedure.
My all-time favorite is anterior hip replacements. They're fun surgeries. I use x-ray in surgery so I can see exactly what implants look like before the real implants go in. We have a bunch of folks helping out, so it's certainly a team approach, but I just see people get up and walk and do so well so quickly, so that's my favorite surgery.
That's cool. Yeah. Do you have a favorite one?
I do. I'm trained from the clavicle to the fingertip, and so I do a lot of different surgeries, but I have a special passion for shoulder replacements. And so I'd say if I had to pick one surgery that I really love is I'd say the reverse total shoulder replacement. And just, similar to the hip, the planning that comes with it, it's kind of like, solving a puzzle of getting the right tension, getting the right implant placement to get the best motion and the best strength afterwards. I think it's a lot of fun to figure that out for every patient because every patient's unique, and so every implant that goes in is a little different.
Can you explain that reverse shoulder thing for people out there?
Sure.
It sounds kind of odd.
What does
that mean?
It sounds funny when you say reverse, right? It sounds funny, and so I always do have to explain it. But it basically, the shoulder joint is a ball and socket, right? And what it does is instead of me replacing your socket with your socket and with your ball, I reverse it, and I put a ball on the socket side and a socket on the ball side. What that does is it changes the dynamics of the shoulder a little bit. It came out about 15 years ago specifically for people that don't have a rotator cuff intact. And so in the old days we were giving shoulder replacements to people even without rotator cuffs, but we found that without rotator cuffs they don't get their motion back, they don't get their strength back. And so what the reverse does is it allows you to use your big muscles, your big deltoid, your lat, your big muscles around the shoulder, not the rotator cuff, to get your motion back. And so it's pretty neat technology that came out, and it works wonderful. Both the anatomic total shoulder and the reverse total shoulder are equally good at getting rid of your pain, and so they're both very, very good tools in the toolbox to have.
So which one would you prefer to do?
I think both are
reversions?
fun. Both are cool to do, but the reverse has a little bit more hardware that you put in, and so a little bit more kind of figuring out the pieces to the puzzle, and so a little bit more of a challenge. And so I'd say if I had to pick one, I'd pick that. And to be honest with you, nowadays as the population ages, we're seeing more and more candidates for the reverse than we are for the anatomics, because more and more people are getting replacements at a later age in life, just because they're getting healthier, they're living longer. And so when you get to a later age, your rotator cuff function isn't as good. And so you end up being a candidate for the reverse.
Is there anything I can do to prevent a rotator cuff injury or need for shoulder surgery?
Staying active is the biggest thing as far as not developing arthritis. As far as the rotator cuff degeneration, there's not a whole lot you can do. But the good news is that even if your rotator cuff starts to degenerate, most people don't know about it. They've done studies where they've actually done MRIs on just general population that don't have any symptoms, and about half of the people over the age of 60 have partial tears or full tears that they don't even know about. So your body does wonderful things at compensating for that over time.
I see that in the office sometimes. People will get an x-ray or an MRI, whatever done, and they come back and say, oh, I got this torn rotator cuff. What do I do about it? And I say, well, are you able to do this and this and this, and can you drive and do all the things you want to do? Well, yeah, but shouldn't I get that fixed? So they don't need to get that fixed, is what you're
Correct.
saying. So you go on function, their lifestyle, age, and other factors too.
Mm-hmm.
So if they never have to raise overhead for some reason and they're 90 years old, they shouldn't be too worried about it then.
Right.
But regardless of the age, what's the youngest person you've done shoulder surgery on?
Well, for rotator cuffs, it can be teens, 20s. You can tear your rotator cuff in a traumatic fashion at any age. If you have a big fall or a big sporting accident or a car accident, the rotator cuff can tear at any moment when it comes to trauma. For arthritis, you see younger people develop arthritis when it comes to post-traumatic arthritis. So if you've had a trauma in any joint, it predisposes you a little bit to develop arthritis. And so you see people in their early 30s developing arthritis that have had either multiple traumas in the shoulder or multiple surgeries in the shoulder, and the dynamics just change, the force factors change, so that the cartilage starts to wear out. And so it can be any age, really.
Just a reminder, you can still send in questions for us. You mentioned some of the other specialists in this building. I think we may have missed a couple. So what other services are in this building?
So on our floor, on the third floor, we have orthopedics. So we have hand, upper extremity specialists, hip and knee specialists, sports surgeons that are all kind of in one part. We've got the non-operative sports medicine doctors and podiatrists. So they'll deal with anything with regards to the foot and ankle and all that entails. On the second floor is the spine, interventional pain and neurology team. So they will deal with any sort of back or nerve issue. They have all sorts of non-operative options for back pain or for chronic pain in different areas like the hip or the knee as well. And then neurology, of course, for kind of different nerve-related issues.
Amanda.
Yes.
I don't want to forget about you as far as the team approach. What would be the most kind of challenging patient you have trying to get them ready for surgery?
So it's patients that have like significant comorbid conditions. We have to work, very hard to get their clearances from their providers. So we, like I said, sit down and do that health risk assessment with them. And if they have multiple comorbid conditions, we want to make sure that they're cleared from every single one of those providers. So if we have to reach out to 8 different providers to get that clearance, it's going to be difficult. It's going to be a lot of work, but that's what we're there for. We're there specifically for that patient to make sure that they're at the best state of health for that surgery. The thing I think they may have touched on a little bit is the therapy. That's usually my most difficult thing after surgery is getting patients to do that therapy because, as they mentioned, it hurts. I don't want to do it. But it's doing the therapy that really helps that pain. So one of the things that I always tell my patients, we go up and see the patients in the hospital. So, we don't just work with them prior to surgery. We see them in the hospital, do education, make sure that they understand all the information that they're given. you know, like I said, give them our business cards so we're their liaison. They call us for any needs at all. And pushing that therapy is going to be the biggest thing. And, you know, a lot of people, like I said, don't want to do it because of the pain, but working with them and getting them to understand how important it is, it's rewarding once they call you and say, I should have listened to you in the beginning. Like this is, you're right, the more I move. But one of the golden rules I tell patients, especially for my hip and knee patients, is every 45 minutes to an hour, get up and take a short 5 to 10 minute walk, because the stiffer that joint gets, the more pain you're going to have. And, you know, once they listen to me and they do get up and walk, they're a lot happier, and you know, they appreciate that. It's unfortunately, you have to give a little bit of tough love sometimes just to get them to listen, but once they do, they really appreciate you.
That's what I hear at Greenfield. Part of what therapy is motivation, to get people to
Yes.
move.
Yep.
And the inpatient physical therapists, they will push patients
Yep.
because they know it's in their best interest, and they will really work them. Those people are tired about 4 o'clock in the afternoon. They're ready for a nap. They're
Yeah,
done with
absolutely.
therapy.
We're all about the patient's best interest. That's what we're there for. We want you to meet your goals. We are there for your best interest. We want to ensure that you have the best possible outcome. And even if it's that pushing you a little bit further, you know, we do it just for you, to help you.
Where all can they go for their physical therapy?
So Adena has multiple locations throughout the surrounding community. So if you are a candidate for outpatient therapy, we have Greenfield, Jackson, Hillsborough, Waverly, Fayette. Here in Chillicothe, we have rehab facilities. We also can work with you if you are out of our county region. We have patients that drive 2 or 3 hours, and we don't have service lines there, but we'll work with them and get them into whatever facility that they want to go to. If they don't have support at home, then home health is also an option. So we will work with them, getting them set up on different home health agencies as well. Patient preference is always the key, so we always want to know what their preference is. So we'll set them up with whatever home health agency they prefer, outpatient therapy they prefer. And then, like Dr. Meschbach mentioned, if you can't go home because you don't have anybody at all for those first couple of weeks, then we'll send you to, like she said, our preference is swing bed, because they do, work with you a little bit more. But if that's not an option for you, then we'll get you into whatever nursing home facility you need to go to as well.
Great. This hospital is beautiful, wonderful, great facility. If there is need for cardiology or other specialists, I'm assuming we're connected to the hospital and the services are available up on the 4th floor.
Yep.
For consultations.
Absolutely. There's been quite a few patients that we've noticed after doing labs that, it looks like their kidney function is not, where it should be, but they've never seen a nephrologist or a kidney doctor before. We'll make that consult appointment for them because, like I said, we have their best interests in mind. So we don't want to, sign them up for surgery and do surgery on them knowing that their kidneys may not be functioning as appropriate as they should be. So we'll make sure that we have a kidney specialist, clear them and say, yeah, they're good to go for surgery. We don't want to put any more damage on those kidneys than what's already going on.
It's not all about the joints, sorry. There's some other organs that have to pump the blood through there one way or the other. A lot of people in Southern Ohio are smokers. Tell us again about the importance of stopping smoking before surgery, because people think, well, I'm going to smoke my last cigarette right when they're wheeling me down the hallway, to go to surgery. So anyone want to join in terms of why it's important to stop smoking before surgery?
At least from a hip and knee joint replacement perspective, the nicotine in your system makes it tough to get blood to that area. Number one, to help it to heal, but also to fight off infection. So smoking is a pretty big risk factor for infection, which can be devastating in any sort of joint replacement. So research has shown that at least having that out of your system for 6 weeks prior to surgery will give you the best chance for success.
Wow, 6 weeks. That's tough. That's part of the motivation of having joint surgery done. Get your physical therapy, stop smoking, get your weight down, try to exercise, be everything as healthy as you can up to the point. I think also for anesthesia, it's important to not be a smoker too.
In terms of your lungs as well.
Exactly.
Yeah.
You need to get that oxygen in and out. In terms of comparing your training to to what you do here. Is there anything else that you were trained to do that like to expand any procedures here in the future? Is there anything different or on the horizon that you plan to kind of bring to us?
We do have a robot here that can be helpful for hip and knee replacements. It's called Mako. I'm Mako certified as well as a number of the other surgeons here. So the Mako can be used for partial knee replacements, total knee replacements, anterior and posterior hip replacements. It's a great technology. It's not necessary, I think, for every joint replacement, but it's certainly helpful if you have any sort of different anatomy that would make doing a regular joint replacement difficult. So that's definitely a service that we offer here that we're certified in.
Let's talk about, we didn't talk about robots yet. I've got patients who think a robot does their surgery. It's like, no, not exactly. So can you explain how a robot would help in doing your practice?
So prior to undergoing robotic surgery, you get a CT scan. So that gives you a 3D picture of the hip or the knee joint, and that helps with surgical planning. So with engineers, we can template what the perfect size implant would be, what would fit perfectly in your bone, but we can determine exactly how much bone we need to take out to fit these implants. So it can be bone sparing if we're not having to remove as much bone as with a normal hip or knee replacement. It is very accurate in terms of the bone cuts that we make. That's what research has shown the most of, that it's highly accurate. It avoids outliers in terms of alignment of the hip and the knee. So the jury's kind of still out on the long-term benefits of this, if it's different than a regular hip or knee replacement. But there are some folks that would not be able to have this without robotic assistance. So with the help of the CT scan, we can kind of take a better picture of the bone and figure out where's the best place for this implant to match up with the anatomic and mechanical alignment.
So that's how it works. Well, thank you very much for being here, Dr. Meschbach, Dr. Barrazueta, and Amanda Ashworth. Any last words before we wrap up?
Just want to add that I think Adena is wonderful, and I, from the bottom of my heart, would say I would send anyone in my family to one of the providers here.
Awesome.
100% agree.
Awesome, awesome. Well, if they want to make an appointment, they can call 740-779-4598 or visit adena.org/appointment. And I think that's all. Thank you very much.
Thank you.
Thank you.